Okay, so a very good morning, ladies and gentlemen. Thank you for joining us this morning. And we're just starting up. And uh, uh, as usual, housekeeping rules, please kind of keep your mics off as well as the videos, and then feel free to kind of drop your comments, questions, anything in the chat box. We'll be very happy to kind of go through that. Now, just a couple of changes to what we usually do, and these are actually very administrative, actually. And I mean, just following with the MMA's guidelines, what we'll do is now we put up a QR code for you to scan your attendance, and we'll do that right at the end. So right at the end of the session, we give you quite a bit of time. Please then, at that point in time, scan your QR code and put in your attendance. That then goes directly to your app as well. So yep. Otherwise, we should be able to kick off. We're right on time, as we usually kind of are. This morning, we're very privileged to get on to our next session of the SK Dharmalingam lecture series. And we actually took a break over last month due to Idil Fitri, and now we're just swinging this back in. And we're very privileged this morning to have with us Professor Dr. To Lai Man. Really, Dr. To needs no introduction, but anyway, it's always nice to kind of reintroduce him in case there's a new set of people or newer people who are just joining this series. He's a very frequent speaker with us, and in his own capacity as well. Dr. To speaks at various other sessions, conferences. He's always very involved in sharing, creating more education awareness to both healthcare professionals as well as to members of the public. Dr. To is a consultant clinical oncologist, and he's the head of oncology at Beacon Hospital. He's also a co-founder of Lung Cancer Network Malaysia. And really, it's, I think, with this hat that Dr. To is primarily wearing as he speaks to us this morning, as this is World No Tobacco Day coming up to the end of this month. And in the biggest kind of most difficult cancer that we all deal with today, lung cancer. And I use that term simply because still 90% of our cases in Malaysia are detected in almost the penultimate stages of disease. And still, unfortunately, the biggest problem, despite, we start seeing a rising number of lung cancer from other sources, unfortunately, tobacco smoke remains one of the primary risk factors and primary drivers of lung cancer within our country, with about 5 million smokers. So this morning, we are hoping that Dr. To will kind of give us very invaluable insights into how do we actually pick up lung cancer, how do we manage smokers, because really it moves across the realm of science of medicine into the art of actually caring for that individual patient that we have. So without further ado, please allow me to turn the stage over to Dr. To. Doctor.
Thank you very much, Dr. Murali, for your kind invitation to speak. And thank you to our audience for lending their precious time on a Saturday to listen to a bit more about a topic which I think, in my opinion, is increasingly becoming more important, that we all as medical professionals comes to grip with, because the incidence of lung cancer is expected to rise in Asia especially. 2/3 of the lung cancer in the world happens in Asia. A lot of it in China, but an increasing incidence in the ASEAN region as well. So Dr. Murali, just to clarify, in terms of our audience today, are they mainly healthcare professionals, Dr. Murali?
Yes, Dr. To, this is a closed session for healthcare professionals.
Oh, I see. So I wasn't aware. I thought it was for the public.
Right.
Okay. Okay. So I think just to start off, the starting point for any disease is probably just to understand its significance and impact upon the local population. As you can see here, this is 2012 to 2016 data. Lung cancer is the top 3 cancers in Malaysia. And I think this is an underrepresentation for all of us who know that in the population, there are many people who present with in old age with so-called pneumonia and sepsis, but we never do a biopsy, and especially not going back in the too distant past, these people are just labeled as having old age or pneumonia. And I think lung cancer, certainly in a global perspective, is one of the most common cancers, and certainly the top disease burden or mortality burden experienced in the Asian region, as in ASIA, Asia. In terms of the male-female preponderance, it's more commonly found in males. It's a close second in terms of incidence in the male population in Malaysia, and the fifth most common in the female population. But we can see a trend of increasing females who get lung cancer, especially non-smokers, and we'll come to that later on in this talk. About close to 20% at least of my patients who present with lung cancer are so-called non-primary smokers. In terms of the, oops, can I just, in terms of the ethnicity, the lung cancer is most common in the Chinese population, as opposed to two other main racial groups in Malaysia. It's followed by the Malays and followed by the Indian population. In terms of age, you can see that lung cancer is a disease that's associated with aging. We have our rise in incidence round about the post 40 years old, with the average diagnosis in the male population in Malaysia at about in the 50s, as opposed to global median age at about 65. So we see an earlier group of patients with lung cancer in Malaysia. I think this is probably tells a huge story. This graph here shows, these pie charts here show that the majority of lung cancer in Malaysia is diagnosed in stage 4. About 80% of lung cancer comes for the first presentation to a medical professional at stage 4, where they are spread outside the lung and gone to the liver, bones, brain, and so forth. And this eventually reflects in the cure rates of Malaysia being very much lower than a lot of other countries, especially developed countries, even our neighboring countries such as Japan, Korea, and so forth. Over 90%, 90 to 93% of our patients are at least locally advanced and metastatic, as opposed to stage 1 and stage 2, which is potentially curable. And so this becomes one of the focus for the activity for those of us interested in lung cancer, is to really try and find ways to bring about stage migration, which means trying to detect patients earlier in stage 1 and 2, as opposed to stage 3 and 4. I'll just get back to this. Interestingly, as our audience here is, I'm sure consists of general practitioners, we have, I'm the co-founder and vice president of Lung Cancer Network Malaysia. We are a group of interested parties of professionals. We have in our group surgeons, oncologists, general practitioners, physiotherapists, respiratory physicians, dietitians, nurses, and so forth. We've managed to partner with an industry partner as well as a general practitioner group to bring in automated artificial intelligence with deep learning software to read chest x-rays automatically and give the general practitioner a report to give you a risk of that x-ray showing a lung cancer. And we hope to bring you more information about this. We've just signed an MOU last week, and we'll be bringing this into Malaysia as a very first initiative. And this is the same software that people have used to detect COVID and pulmonary TB in an automated fashion. So following on from the slide of presentation stages, this slide is really telling. As you can see, breast cancer has a 5-year survival of 66%, all stages, versus lung cancer at 11%. And lung cancer is really champion of the charts in a bad way. As for colorectal cancer, the cure rates are much higher as opposed to lung cancer. And really, we're not doing well, even compared to pancreatic cancer. But I mean, these are slightly older figures, and I hope to show you later on that with newer modalities of treatment, we're seeing a complete reversal, a complete paradigm change in the way we treat lung cancer. So I think this graph is very obvious. I mean, clearly the chances of you bringing about a good outcome treatment depends on the stage at which you treat your cancers. But even for stage 1, we're looking at a 5-year survival of 37%, which is actually below our global figures. So really for stage 1, we should be looking at about 80+% 5-year survival. So perhaps Malaysia, we still have a way to go in terms of what we're trying to achieve. But for stage 4, I mean, we rarely get, in the past where we only had radiotherapy and chemotherapy, we rarely got patients who survive 5 years. And I think this 6.3% survival is really an overestimate. So this again shows our, oops, sorry. This again shows our figures compared to our neighbors, Japan and Korea, where they have instituted screening, they have meticulous multidisciplinary team working, they have access to many clinical trials, can produce, oh, I'm really sorry about the background noise, survival rates of 29%, over 20%. So what we've talked about so far is that lung cancer is a very common cancer. The late stage of presentation certainly is a major factor. And we see poorer survival compared to our neighbors. The ethnic Chinese seem to be at more risk, and aging, lung cancer seems to be a disease of that's related to aging. I'm not sure if you want to make this interactive. I can stop here after the presentation of the epidemiology and maybe take a few questions. Would that be all right, Dr. Murali?
Yes, sure, Doctor. I haven't seen any questions yet, so we'll just give it a couple of seconds, and maybe if we have no one typing in as yet, then maybe we can carry on first.
I think you said, looking at your program, you sessioned this for 2 hours, but hand on heart, I don't have many slides, so I don't think I will be able to complete 2 hours of speaking. I did flag any questions, and my presentation is probably 30 minutes or so.
Yep.
Okay, if there are no questions, I'll make a move. Okay, what causes lung cancer? I mean, I think it's obvious. I think everyone knows that smoking causes cancer, smoking causes lung cancer. And this is, what we see on every cigarette pack out there, that the carbon deposition, the tar deposition in a patient with lung smokers is accumulates over many years, and there's a lag time of about 10 to 20 years in developing lung cancer uh, in terms when you have the initial DNA damage caused by the multiple carcinogens found in cigarette smoke. So, but there are other risk factors for lung cancer as well. We have recently discovered from a big study in Taiwan that family history plays a significant role, at least in the Asian population. So if you have first degree relatives, second degree relatives with a history of lung cancer, that does increase your risk of lung cancer. But unlike breast cancer, where we have identified certain causative factor genes such as BRCA, ATM, and so forth, the inherited component of lung cancer has yet to be discovered, but the work is ongoing. So other environmental exposures include industry, where people work in chemical factories, exposed to carcinogenic material, radon gas, asbestos is a big one in the shipping industry, in the roof insulation industry is also a big risk factor for lung cancer. Pollution in general is a risk factor, and we have some data from Europe showing the parts per million particulate matter in the air increases the risk of lung cancer. And having chronic lung disease such as COPD, bronchiectasis, previous TB. TB is a risk factor for lung cancer. These are some of the things that you probably need to look into in terms of the history of a patient that presents to you. And what about smoking in Malaysia? Malaysia is probably not as bad as some of our other Southeast Asian nations, but the estimated prevalence of smoking in Malaysia is about 23% or a quarter of the population. Males more than females. Overall, about 37% or 8 million plus of Malaysians, adults aged 15 years or over, are being exposed to secondhand smoke. And this comes from the National Health and Morbidity Survey 2015. This is a campaign we ran together with NCSM in combination with some of our industry partners to highlight to the public and also to our fellow colleagues that lung cancer can happen in non-smokers. And this is a real patient. It's a patient of mine who presented in the 20s, just on normal routine chest x-ray screening. She was due to emigrate to another country and required an x-ray done. And it showed lung cancer, not in one lung, but in both lungs. So she had bilateral lung cancer, which was not operable. But we did genetic sequencing, and we'll talk about genetic sequencing in a bit, which fortunately showed that she could be potentially very responsive to new generation targeted therapy, and that's what she had, which finally downstaged her and rendered her suitable for curative operation. As we mentioned, there's a rising incidence in lung cancer in women. There is, we don't really know the etiology, but there's some speculation that it's related to cumulative exposure of passive second and third hand smoking. However, the incidence of smoking is rising in the female population overall as well. And we see this, and we see some data from places like China and Korea, where there are more and more women smokers. But smoking in women is also postulated to be related to high temperature wok cooking, where the fumes that are generated from such in a non-well ventilated environment does contain carcinogens. And there's some data from Singapore that those who to engage in high temperature wok cooking at higher risk of lung cancer. but the food generated from high temperature cooking as well is known to contain carcinogens. So is this the main driving factor? We don't know. And also we spoke about genetic mutations, and that's increasingly a big factor in the etiology of lung cancer. Okay, we spoke about this. And how about vaping? I mean, that's the trend now, that vaping, in terms of how it's marketed, is said to be a more friendly or less harmful alternative to traditional cigarette smoking. However, does the evidence support this? I think we know that vaping itself does cause lung damage. So I think it would be completely disingenuous to say that vaping is safe. So we know that in the United States, we've come across EVALI, the EVALI phenomenon, where patients develop very severe broncholytic changes or popcorn lung as a result of vaping. And this may be related to some of the chemicals within it, namely formaldehyde, acrolein, VOC, vitamin E acetate, and THC. But does vaping cause lung cancer? I think the jury is out, because you need a lag time for at least 20 years to get proper data to really define the epidemiologic association between vaping and lung cancer. And we don't have that yet. Vaping is a relatively new phenomenon, but certainly as a medical professional, I wouldn't, if a patient were to say to me, look, can I do vaping instead of smoking? Would that decrease my risk? I think hand on heart, the answer is we don't know. And intuitively, I feel that answer is probably going to be no. Okay, so we've spoken about the fact that if you can detect these cancers early, you have a higher chance of curing them. And the gold standard for early detection of lung cancer is what we call, or screening of lung cancer is what we call a low dose CT scan, or LDCT. And the data for LDCT has come from two huge, large randomized trials, one conducted in Europe and one conducted in America. So for example, the data from the Nelson trial, where they screened 15,000 patients and detected about, and in about 2% of this detected lung cancer, they use entry criteria of pack year smoking. So the data that we have in the European trials and American trials comes from smokers who have smoked at least 20 to 30 pack years with an age range of 55 to 74. They showed that this produced an overall reduction in lung cancer deaths at 26% at 10 years. So if you really target a particular population that's at risk of smoking, then you have the potential to find these smaller lesions and perform curative surgery or curative radiotherapy on them. So who should be screened? Again, in the US Preventive Services Task Force recommends yearly lung cancer screening for those with a 20 pack year or more history, and smoking or more, and now have quit within the past 15 years and are aged between 50 and 80 years old. So the Lung Cancer Network of Malaysia, the organization I spoke to you about, feels that these criteria cannot be adopted completely within the Malaysian setting, because we know for a few factors that our patients develop lung cancer earlier than the European population. So we have extended our guidelines to 45 to 75 years with a 20 pack year history of smoking. And we have conducted free low dose CT campaigns over the last 2 years So we've partnered with major private hospitals in in the Klang Valley especially, but also in Malacca, to provide free low-dose CT scanning for patients in the month of November. Available through our website. You can go to our website and our hospital partners and present yourself to our hospital partners, big major hospitals that will do the scans and follow you up as necessary or refer you on to the government setting. But the problem is, even though these scans were provided free, not all of them were utilized. And this, I think, highlights the difficulty in lung cancer management as opposed to breast cancer management, where if you give free mammograms, I think the uptake will be is much higher. I may stand to be corrected by Dr. Murali, who's involved in both campaigns and both efforts. But in general, we see a degree of nihilism in terms of lung cancer. So people don't really want to know. They don't really feel that even if they know they have lung cancer, they think it's a death sentence and nothing can be done. And that's the issue or the problem we face in Malaysia. So as I mentioned, the two previous studies were done in European countries and US countries, but we also now have data from a study from Taiwan conducted in non-smokers. In their cohort, they screened people who had heavy exposure of a cooking index of 110 greater. It's a bit too detailed for me to get into, but basically those as defined as the number of days of frying per week and the number of years of cooking. To cut a long story short, in the Taiwan study, the diagnostic rate of lung cancer was 2.6%. And this seemed to be higher than the European studies. So if even focusing on non-smokers with a high risk of carcinogenic exposure, they found the pickup rate to be very high. And there were more women than men in this cohort. So can we adopt these Taiwan studies to the Malaysian setting? I guess the data is sound. We really need to analyze this carefully and really see whether this can be to see alignment in the Malaysian population. This is something to be considered and offered to our local patients. So the changing face of presentation of lung cancer, we know that there's increasing incidence among non-smokers. There are more women developing lung cancer. We have a younger population, and certainly the issue about genetic inheritance and mutations is a significant one. We see mainly non-small cell lung cancer, 85%, and we also see some other types of cancers, such as small cell lung cancer, neuroendocrine tumors, which is 15%. In terms of the non-small cell lung cancer, we tend to see more adenocarcinomas in these days. In the past, we saw, going back maybe 30, 40 years ago, predominantly it was squamous cell carcinoma. By that, the trend has completely reversed. We see predominantly adenocarcinomas nowadays. Okay, so I think I'll again stop there. The next couple of slides are about how you diagnose, stage these tumors, and treat them. But before I go on to that, are there any questions about the screening of lung cancer, as well as the epidemiology and so forth?
Okay, Doctor, there are two questions so far. One is on whether one of our colleagues asked whether is there a cancer marker to identify lung cancer in an early age, especially I think within females and non-smokers.
That's a great question. Okay, so I can't remember if I got a slide. Okay, I'm sorry, I missed that slide out. But the answer is yes. So there are there's a panel of tumor markers which has been approved to use in conjunction with low-dose CT scanning. So low-dose CT scanning remains the gold standard. However, we can sometimes find indeterminate nodules. So which means nodules which are not very big, or that may not have the typical morphology of a lung cancer. Because as you know, in this region, we see a lot of pulmonary TB, and in the general population, you see a lot of granulomas. So one of the drawbacks of introducing low-dose CT scan in a population such as Malaysia or somewhere like Philippines or Indonesia is the high incidence of untreated or unrecognized tuberculosis. There are a panel of tumor markers. They are proprietary. They are not approved in Malaysia at the moment, but they are approved in other countries, so I'll probably not speak too much about it. But there are a panel of tumor markers. They are not the typical type of tumor markers that you do in the clinic, such as CEA, CA153. They are more specific for lung cancer. There are CIFRA, SCC antigen, and so forth, that you use in conjunction with your low-dose CT scan in indeterminate nodules. But if you were to ask me whether you can replace low-dose CT scan or just use blood tumor markers to detect, the answer is no. The typical screening tumor markers that you do, the CEA, the CA125, the CA153, tends to pick up lung cancers at a later stage. So they may not pick it up when they are 1-2 centimeters. They may only start to rise when the tumors are 3-4 centimeters. Of course, there's individual variation between patients, but this is generally what happens. So you get a false negative result at early stages with tumor markers. False negative result.
Okay, there's another question. I think I quite kind of similar on the similar track, Doctor. One is on low-dose CT scan. How available is it? How frequent should we be ordering it? And there's another one on should we do chest X-rays prior to low-dose CT scans?
I think the answer is no. You don't do a chest X-ray prior to low-dose CT scan, simply because the resolution of a CT scan is generally quite poor. You know, you have tumors in the sometimes in the inferior bit of your left upper lobe, which is behind the heart, or your right middle lobe, which is obscured by the cardiac shadow. Unless you do an anterior and a lateral, you miss these tumors. So chest X-ray is not recommended for so-called screening. The cost of a low-dose CT scans, I would say, since Lung Cancer Network Malaysia has come into the picture, we've actually raised the awareness such that a lot of private hospitals are offering low-dose CT scan. Low-dose CT scan is done without contrast, so you don't need to fast. There's no needles, there's no injection of contrast. It's done in a single breath hold, which takes about 10 seconds to do. The amount of radiation that you get is 1/5 or less than 1/5 in good centers of a normal CT thorax. So it's low dose. It's 1/5 the dose. It's done without contrast. It's done within 10 seconds in a single breath hold. The cost of it varies. In the government setting, in fact, Malaysia had tried to introduce low-dose CT scan in the KKM setting in a big clinical trial that they initiated about 5 years ago. But unfortunately, the clinical trial was stopped because there was not enough uptake. Not enough patients had the motivation or interest to go for a low-dose CT scan. The cost of a low-dose CT scan in private ranges from 300 to about 500 ringgit. I'm sorry, did I answer the question?
Yep, and I think how frequently should we be kind of pushing this. Yep. Yes, doctor.
So in the Malaysian context and in the clinical trials that were done, this was a one-off scan. So it's not like breast cancer where we have a certain time interval that you do the scans, every 3 years between 50 to 70 for mammograms and ultrasounds. For lung cancer, it's just a one-off. So that means you have a patient with a high smoking history and you determine to have a higher than normal risk of lung cancer, you do it as a one-off. It's not repeated. However, it's left to the clinician's discretion to also repeat the scan as necessary. But the official recommendations is a one-off. But studies have shown by patients actually agreeing to go for the low-dose CT scan and undergoing the anxiety of waiting for the results, in I think 30 to 40%, that acted as a catalyst to stop smoking, or at least seek advice from healthcare professionals on how to stop smoking, nicotine patches, and so forth. So it had a byproduct benefit. So the low-dose CT scan actually triggered the patient, the potential candidates or the patients to live a healthier lifestyle and to stop smoking. Because we know that even if you stop smoking after you've been smoking 5-10 years, at the point you stop smoking, there is associated risk reduction in terms of your of lung cancer. Although it doesn't return back to baseline or normal, but the risk reduction for stopping smoking, even after you've been a smoker, is significant.
Doctor, on the same line, there is, I think there's another colleague of ours who asks, are there guidelines should we refer to? I think and there's another question on criteria as well. Gentlemen, that criteria or the screening recommendations, what is on the screen right now. So have a look at that, and you could put on a screen like a snapshot straight away if you wanted to. Now, however, there is also a question, doctor, on is it available in the government setting, and how do we refer to get our patient to get it?
Okay, since the completion of the clinical trial is not available in the government setting, as something that you can write a letter of referral and send it to government, and they will get the low-dose CT scan. However, I suppose if you see a respiratory physician or an oncologist in the government setting, and they feel that you are potentially high risk for lung cancer, they may order a low-dose CT scan.
Okay, which means through the RESPI team, it can actually be ordered and done in specific tertiary hospitals.
Right. But I think it's not certain that it will be done, and probably be done on an ad hoc basis for high risk patients.
Okay, got it, doctor. So I'm just moving out from this curve, doctor, back into like another track of questions. There's a question from a colleague on whether chewable tobacco is in any way associated as a risk factor for lung cancer.
Probably much less risky than smoking. Chewable tobacco itself, and the associated chemicals that's required to manufacture and preserve the product will probably increase the risk of oral cancers and throat cancers, but probably it's not so significant in terms of lung cancer. And we know that the chewing of betel nut and tobacco products in India, for example, you see a lot more base of tongue, molar, jaw cancers than we do in Malaysia.
Right. Okay, doctor. And there's a couple of questions which I'm going to leave in the sense that I think you'll be covering that in the next couple of slides, and then we'll come back to them. I'm just going to ask you one more question, doctor, which is relevant to what we've been talking about. It says, in the very high-risk patient, smoker with a first-degree relative, lung cancer positive, should we screen all without considering the number of pack years smoking?
Yeah, so the data that we have is from the relative risk of developing lung cancer. If you have a first-degree relative who's a father, is 0.7, but if your mother 1.4, brother 2, and 1.7. Father probably not so high because father may have developed lung cancer from 0.6, 0.2. So really we're looking at the immediate family. So this comes from the TALENT, TALENT study in Taiwan, 12,000 people. Data comes from 12,000 people. So in Malaysia, we don't have guidelines for this situation for non-smokers. And if it's
Sorry, doctor.
cooking index of more than 110, I need to refresh my
Sorry.
memory of how they actually came up with the 110 figure.
Sorry, doctor. I think the line's a bit poor. Shall we switch off the video? That might improve the connection a little bit.
I lost you, Dr. Morali.
No, you logged off, doctor. The connection was really bad.
Oh, okay. I'm so sorry.
No problem. Now it looks much better.
Okay.
Shall we go ahead?
I'm sorry. There's a lot of background noise. Can you hear a lot of background noise from my end?
Not so much now.
Okay, great. Okay. Hold on. Okay, so once we've detected a lung cancer, how do we treat it? So the typical history of lung cancer is someone who has cough which doesn't resolve, and had multiple rounds of antibiotics, probably went to shop around doctors and were given different antibiotics over a period of time. A history of shortness of breath. If the tumor invades the subcostal nerves or bones or the paravertebral region, then you may get pain associated. And if the patient has a pleural involvement, they can get pain on deep inspiration, pleuritic chest pain, and sometimes if we see patients with hoarseness of voice, that tends to be left-sided tumors which invaded the recurrent laryngeal nerve, causing vocal cord or partial vocal cord palsy, unilateral palsy, and generally weight loss. It's confusing because a lot of patients are smokers and they're quite underweight anyway. But weight loss is one of the signs of lung cancer. What else in the history? So hemoptysis is a very worrying sign of lung cancer. There are not many conditions that give you hemoptysis apart from a massive pulmonary embolus or some sort of vascular dysplasia, which is exceedingly rare. So hemoptysis is a big flag, a big warning sign for lung cancer. Physical examination, to be honest, you don't really see that very much unless the patient is really advanced and you're starting to get Horner syndrome, vocal cord palsy, a mass that is protruding or bulging. Really, lung cancer is diagnosed from the history and a timely chest X-ray in your initial or general consultation.
Sorry, doctor. Just to check whether you're sharing is there a slide share on? Because we can't see.
Oh, I'm sorry. Hold on. Is that better?
Yes, this is so much. Thank you.
Okay, sorry. Okay, so low-dose CT scan we've spoken about. Low-dose CT scan really is used when you suspect early lung cancer or and used as a screening tool. So if your chest X-ray already shows some findings, and if you're highly suspicious based on the history that the patient has locally advanced or advanced lung cancer, I think I would skip the low-dose CT scan and go straight to a contrast enhanced CT scan of thorax, abdo, pelvis, the standard modality for diagnosing these sort of conditions. A PET-CT scan is a specialist scan that's done once a lung cancer diagnosis is confirmed. So once the biopsy has been done, you have in your hand a histopathology report that tells you that this is lung cancer. That's when a PET-CT scan is done. So a PET-CT scan combines metabolic information about the tumor as well as anatomical information about the tumor. It shows up, is more sensitive in detecting tumors, particularly in the lymph nodes and in the bone. So CT scan is notoriously unreliable or non-sensitive for bony metastases, whereas a PET scan combines the value of doing a bone scan as well as a CT scan all in one. So if you have an earlier lung cancer, let's say there does not appear to be any metastases outside of the thoracic cavity, what the oncologist and the surgeon wants to know is, are the hilar and mediastinal lymph nodes involved? I think that's the real key to decide whether this patient is suitable for surgery or whether or in radiotherapy, or whether we call them palliative, they're too advanced. So if the lymph node spread is just to the hilar region and maybe minimally to the mediastinal region, this patient certainly could be considered for surgery as the curative modality. If it's gone to lots of lymph nodes in the mediastinum and even gone to the contralateral hilar region, we're now talking about using radiotherapy as your primary modality of treatment. I won't go into so much detail about explaining what mediastinoscopy is, VATS, and so forth, but in order to get tissue, nowadays, more and more, we are leaning towards getting a CT-guided biopsy. So the interventional radiologist is our big friend, and they really are very helpful in giving us the diagnosis. Less and less, we are doing bronchoscopies because the number of centrally located tumors, that means tumors which are found right next to your bronchus, where when you do a bronchoscopy, you can actually see it and take tissue from it, are less and less. They tend to be in the middle of the lobe or the lung, sometimes in the periphery, but mainly in the middle, where it's not accessible via bronchoscopy. So we need to do CT-guided biopsy. And the other advantage of doing a CT-guided biopsy is we can take more tissue. We can get bigger cores of tissue, and that tissue is very important for us to do molecular testing or genetic molecular testing on what kind of tumor we're dealing with to offer the best kind of treatment for the patient. Okay, so so I think I'm not a surgeon, but if anybody wants to discuss surgery, I'm fairly well versed with the kinds of surgery available for lung cancer. Certainly for stage 1 and stage 2, the treatment for lung cancer really is underpinned or undergirded by good surgery. And the surgery involves taking out the tumor as well as the hilar lymph node and associated draining mediastinal lymph nodes. Only then do we get proper staging information as well as clearance of the potential draining lymph nodes. Surgery, we do not recommend pneumonectomy in this day and age, which means taking out the whole left side of your all the lobes in your thorax. The gold standard for surgery is a lobectomy, which means taking out the lobe in which your lung tumor lies in, not segmentectomy. We do not encourage a wedge resection or just taking out the tumor with a 1 centimeter or 2 centimeter margin. We recommend lobectomy, taking out the whole lobe. So your right lung has 3 lobes, your left lung has 2 lobes, taking out, the relevant lobe. Of course, the patient must be worked up very well prior to surgery to see whether it's fit enough, proper lung function tests, the FEV1, FEC, the transfer factor. But to be honest, one of the best ways to see if a patient is fit for surgery is to ask him to walk up a flight of stairs. If they can manage a flight of stairs and come down and be not too breathless, certainly this patient should be considered to at least discuss with the cardiothoracic surgeon. From my point of view, I'm a oncologist, which means I do systemic therapy and radiotherapy. Systemic therapy is traditional chemotherapy, but more and more we are relying on immunotherapy and targeted therapy as the mainstays of our treatment. So the first new kind of modality I want to talk about is immunotherapy, and immunotherapy has been, covered widely in the traditional media, in the scientific literature. It's really the biggest new kid on the block. It's even newer than targeted therapy, and used in the right way, in the right hands. We have had patients living with stage 4 metastatic disease, brain metastases, more than 5 years. When you do a scan, the scan is totally clear. Is this a cure? I mean, you can see Time magazine says, how do you cure cancer? It's a bit of it's meant to be a bit of a headline grabbing meme or statement. But really, we do see patients living much longer, 5 years, 6 years, 7 years, with a clear scan who have been on immunotherapy. Certainly the literature from melanoma, which in the past was a death sentence within 6 months. Melanoma is completely resistant to chemotherapy, but using immunotherapy, not uncommonly, you see people survive 10 years. Former President Jimmy Carter had melanoma with brain metastases. He had immunotherapy. I think it was 2015, and I believe he's still around. What is immunotherapy? Immunotherapy really is a process where we try and enhance our body's immune system to find and find the cancer cells and eliminate them. Because cancer cells, you see here in this diagram, the T cells are in white, just a graphical representation, and the cancer cells are in yellow. Cancer cells can avoid being killed by firstly being invisible to the tumor, and even if they are visible to the tumor, cancer cells can be invisible to the T cells, and even if they are visible to T cells can recognize them. They can produce cytokines and many different factors to prevent attachment of the T cells to the cancer cells. So we have drugs now that promote the ability of the T cells to recognize the cancer cells. We have drugs to promote the production and the priming of T cells. And we have drugs now that when the T cells attach to the cancer cells, eliminate don't kill me signal from the cancer cells. So the situation is very much like a Trojan horse. So where the good guys, the bad guys, the enemies are hiding within a Trojan horse. A bit like a computer virus, the Trojan horse story is relevant, explains very well the situation in our bodies when we have cancer. So actually we have enough T cells. It's not that, you say, oh, our immune system is poor, we don't have enough T cells, we need to boost the number. We have enough T cells. It's just that these T cells are not able to recognize the cancer cells because they are camouflaging within the Trojan horse. So this is some contemporary data from our studies. So using immunotherapy alone, the results we have so far in stage 4 patients is a 32% 5-year survival. This is compared to almost 0 5-year survival in the era of chemotherapy alone. So now we are combining immunotherapy and chemotherapy together. We expect even better results when we combine the two together. So instead of 1/3 of patients with stage 4 incurable lung cancer surviving 5 years, we may even see better results. And certainly the early projection or the early results in our clinical trials suggest that the projection may be even better than 32%. So just some examples of tumors which are treated with immunotherapy. This is a man with a left lobe mass in the paravertebral area, very close to the pleura, treated with immunotherapy. You can see a very good response. And this immunotherapy, by the way, is made it into all the guidelines worldwide. So it's not something unique, novel, out of the box. It is in our standard medical guidelines. So this is a patient who had a lung cancer and metastasized to the liver, causing a huge liver mets. His bilirubin was high, and he had multiple lung mets treated with immunotherapy, who had a complete response. And the beauty about immunotherapy, not only do you get very impressive shrinkage of the tumor, but you get potentially you can get a long-lasting effect, which means once you've modulated the body's T cells in the right way, and there is a skill to this modulation, a lot of people do it, but they don't do it correctly. They overmodulate, they cause problems with autoimmunity. But when you modulate the immune system in the right way, you can get memory T cells which remain in your body that remember how to kill these cancer cells. So when new cancer cells emerge, these T cells then reactivate, they proliferate, and they kill off your cancer cells. So literally, you're priming like a reserve warrior population in your body that remains there. Unlike chemotherapy, when you stop the chemotherapy, most likely the cancer will grow back again because you've removed the treatment that is suppressing your cancer cell. So that's immunotherapy. And the next thing I want to talk about is stereotactic radiotherapy. As the name suggests, stereotactic means very accurate. And radiotherapy, we use conventional radiotherapy, but really the right word is radiosurgery. So conventional radiotherapy is given over a few weeks, 6 weeks, 7 weeks, and small doses are given every day. Averaged out over a 30-day or 35-day treatment period. And the reason for averaging it out and giving it in smaller doses is because radiotherapy is toxic to normal cells, and you give too high a dose to your conventional cells, they don't have time to repair and they will die. So the idea behind giving a time period between treatments is to allow your normal cells to repair. Whereas cancer cells, they don't repair so well, but they do also repair. So for example, you have a tumor, next to a nerve, for example, your spinal cord, and you're so worried that if you give too much dose in one go, the spinal cord doesn't have time to repair. The patient may end up with paralysis. If you have a tumor next to your optic chiasm, your optic nerve, similar sort of considerations. So but we know that if you give a huge dose of radiotherapy and you don't give time for the tumor to repair, you get much better results. So for example, in the lung, if you're treating a patient over 30 days or 6 weeks, the cure rate is about 30%. But if you give all your treatment within 5 days, within a week, the same dose or slightly higher dose, you're getting a cure rate of excess of 80 to 90%. So why don't we give all patients this huge mega dose of radiotherapy? The reason why is the lung moves. As you breathe, your lung moves. You can't help it. That's physiology. And prior to today, we didn't have the technology to be able to track that movement in an accurate fashion. But the good news is we do have that ability now. So our machines, especially something like what I'm showing you, TrueBeam SDX, available in my hospital, Beacon Hospital, we have the ability to study the patient's lung movement and be able to create an algorithm, and the machine learns of how the patient moves. And we apply the radiation, we can apply the radiation in at certain points, really focusing on that tumor, and therefore we can now deliver treatment in a much shorter period and a much higher relative effectiveness. So this is a patient, for example, in 2015 who had a tumor, a stage 2 tumor next to his mediastinum in the right upper lobe. As you can see, the tumor is very close to the pulmonary trunk and the main pulmonary artery. This patient should be treated by surgery, but the patient had a lot of comorbidities. They had diabetes, heart attacks, renal impairment, and the anesthetist felt that the patient was not suitable, medically suitable to undergo treatment. So we applied stereotactic body radiotherapy or high dose radiotherapy given over 5 days. And this is the result. November 2005, the main bulk of mass have disappeared, but you see just faint uptake on the PET scan. That isn't tumor, that is actually inflammation. And you get inflammation after radiotherapy, that's quite normal. And therefore, these kind of patients need to be followed up with radiologists who are familiar with the appearances of the scan after we do our sort of treatments. But then in June 2016, you can see the area is now cleared up. So this was 2015, and the patient is still with us, and you can see that we've offered a painless treatment to the patient. There's absolutely no discomfort. You don't get any skin burning. There's no vomiting. There's no hair loss. The patient just walks in, gets the treatment over 10 minutes, 15 minutes, and goes home. And this, you know, and this kind of thing is being offered routinely now. So this is conventional radiotherapy on the left, where this is the tumor there at the posterior bit of your right middle lobe. You get a lot of fall off dose. The red area is the highest dose that we intend to deliver tumor, but you get a lot of this fall off dose. But with newer software, new technology I'm talking about, you get a very highly focused point of radiotherapy and dosage just to the tumor. So we've spoken about immunotherapy, stereotactic modern radiotherapy, and now let's talk about molecular therapy. Molecular therapy really is taking the tumor cells and doing a whole battery of tests on it and making sure we find out exactly what genetic mutations are seen in that particular tumor in your particular patient, and it's different from patient to patient. So in Malaysia, we know that EGFR is the most common gene that is mutated. Our local data suggests about 40 to 50% of our patients have EGFR mutations. It's higher in the non-smoker population and it's lower in the smoker population. But we also have other genes such as ALK, ROS1, here we go, EGFR 40 to 50%, ALK, ROS1. This is the standard genetic mutations we test for, but we also test for things like MET, HER2, BRAF, RET, and NTRK1 nowadays. And all these have targeted therapies that we can use instead of chemotherapy. And as you can see, I'll show you, the results are much better than what we can achieve using conventional chemotherapy. So this is a patient who came into my clinic in many years ago now, in a wheelchair. She wasn't able to talk very well. She had dysphasia. She had unilateral hemiparesis. When we scanned her brain, and her body, she had a lung cancer basically that had spread to her brain. She had 50 brain metastases. Each of these white dot is a brain metastases, enhancing with gadolinium with central necrosis. She was in an extremely bad shape. So fortunately, when we did her molecular analysis, she was EGFR positive, which means she was susceptible. We could use oral molecularly targeted therapy, literally 1 pill a day with minimal side effects. And this was a result 3 months later. So she had almost complete response. So I would say at least a 90 to 99% response in her brain. Maybe there was a little bit of enhancing areas left. Literally, she returned from being wheelchair bound to someone who was normal, walked in a clinic, talking to you. Family was very happy, took her to holiday in Bali. And I think that's what cancer patients should really focus on. You know, it's not just about amount of life you have. You really should treasure the time you have with your family, make the most of ability to be with them and create good memories, lasting memories together. And the family were very happy to go to Bali, and yeah, she continued on this therapy and was very well on it. But these therapies are not a cure. So eventually you will get resistance. So the body will develop a resistance, a mutation that will render your tumor resistant to that therapy that you're giving. It's inevitable. But in the case of ALK, for example, you know, you're expecting at least 5 years of good control with your tyrosine kinase inhibitor. In EGFR, you're expecting maybe about 2 years, at least 1 to 2 years of good control. At that point where the patient becomes resistant to your treatment, what we would normally do, or what I would normally do, is to re-biopsy the tumor and go through another process of looking for the resistance mutation. And we have now later generation treatments to treat these resistance mutations. I'm running many clinical trials in Beacon. One of the clinical trials is tepotinib or MET inhibitor, which is the most common mutation that these patients get after initial treatment with EGFR inhibitors. So I think that's the way forward in oncology. You know, we have all these drugs, but general patients do not get access to these drugs, either because they're too expensive, and anyway, Malaysia is not a priority for the introduction of these drugs. But the way to get around it is to do clinical trials. So if you have any friends who are oncologists in Malaysia, I think you should be asking them, why are you not doing clinical trials for your patients? Because places like, it's really the way to get access to all these new treatments for your patients at minimal cost. So again, some few examples. This comes from the New England Journal of Medicine. You know, you have drugs now that literally draw patients back from the point of death. So this patient who had respiratory failure with ground glass changes throughout the right lung, huge consolidative mass in the left lung, after taking a ROS1 inhibitor, basically cleared up from here to here. So that's the power of finding the right mutation and having the right drug to target that mutation. Okay, I've spoken now about treatment. I'll maybe come to COVID and lung cancer in a bit, but are there any specific questions about treatment?
Okay, Doctor, couple of questions. I think there's one on our colleague much earlier as well. He was asking on how does the treatment differ based on the type of histology, let's say versus adenocarcinoma and squamous cell, for example.
Very minimal. Now that's old school. That doesn't really drive our decision making so much nowadays. What really drives our decision making is the molecular targeted, the molecular targets found within the tumor. So this page here. So even if I had a squamous cell cancer or adenocarcinoma, I would do this. And if they were EGFR positive, they would go on to an EGFR tyrosine kinase inhibitor.
Right.
Having said that, there are certain subtypes which don't tend to have mutations, such as the small cell lung cancer subtype. Those are rare for about 5% of my patients. Small cell lung cancer, unfortunately, even though we've done many trials, they don't have mutations. So they rely on conventional chemotherapy and radiotherapy, but we also deliver immunotherapy for small cell lung cancer.
Okay, got it, doctor. Another question on what is the gold standard of diagnosis for bronchogenic CA?
Gold standard is a biopsy. Did I understand the question correctly?
I think so as well. I was reading it directly, exactly how it was asked. I'm hoping we got that. Okay, a question on how much does immunotherapy cost in general? Oh, this is a really general question.
It costs an arm and a leg. Probably have to, I don't know, sell a house or something, or sell a car. I don't know. It costs a lot of money.
But generally, doctor,
So
if you're
again,
looking at, yeah.
So again, I think we are very fortunate in Malaysia. I mean, the drug companies really realize that our per capita spending is not, in the region of Singapore or US. So the cost of treating immunotherapy in Malaysia is lower than the region. However, it's still probably, I'm not ashamed to say, out of the reach of the ordinary Malaysian. That's the fact. It depends. I mean, it's very hard to generalize because the cost differs from drug to drug and situation to situation. But we would say, probably in excess of 10,000 ringgit a month. That's the reason, and that's the reason why I'm also an advocate for clinical trials, and certainly as the head of oncology in Beacon, I am strongly in favor of running clinical trials. And we've managed to get quite a number of patients onto immunotherapy at free of charge, and they'll be able to get the benefit from these newer therapies. Of course, over time, places like China are producing their own immunotherapy versions. They still need to undergo testing. They're not as well tested as the conventional immunotherapies that we get from the West. Potentially, those may be effective. Potentially, they may reduce the cost. But at the moment, I'm trying to skirt around your question because I don't want to give you exact figures or numbers on air. But
Because
probably
one thing is they're changing, they continuously change as well.
they're changing.
Yeah. And just perhaps to our colleague as well, almost all the big institutions, industrial institutions who offer these, almost inevitably now have some kind of pharma assistance program as well. And a lot of them now are like you use for a certain period of time, and subsequently it's free for forever for the length of however that you're on the drug. So there are many different modalities that are coming into place as well, isn't it?
Correct. Not for immunotherapy. Immunotherapy, there are programs, but there's no free for life yet. But for targeted therapies, there are companies which are offering, you purchase for a certain period of time, and then after that, it is free.
Right. Doctor, there's one more question which I don't think so we have yet to kind of look onto, as in terms of smoking cessation. And what's the real kind of risk reduction in terms of percentage? There's a colleague who asks this question.
Okay. I don't know because I'm an oncologist. I don't really go into smoking cessation with my patients. We have Dr. Anza Alias, who is a consultant and an expert in public health medicine as part of our lung cancer network of Malaysia. I can certainly, if you're keen to get literature and material from her, I can certainly put you in touch. I don't want to confuse the issue. I'm not the expert, but certainly the data shows that once you stop smoking, even though you've smoked for 5, 10, 15 years, the moment you do that, there is a risk reduction in your risk of lung cancer.
Right. Okay. Got it, doctor. And okay, so far that's all the questions we have, doctor. Shall we go into the next segment?
No, certainly. I just have another maybe 2-3 slides. So of course the hot topic now is COVID-19, and obviously for lung cancer we're dealing with a population who already has so-called weak lungs. They have chronic inflammatory diseases, chronic obstructive pulmonary airways disease, bronchiectasis, previous TB sufferers, and so forth. So the data shows that people who have lung cancer as well as chronic respiratory diseases, they are at higher risk of severe COVID-19 illness. The data shows that. So probably this population should be at higher priority to get the vaccination done, and higher priority to practice isolation measures. But yeah, which is part of the phase 2 vaccine rollout. Such patients should get higher priority. Smoking itself is found to be a risk factor for developing severe COVID-19 illness. Smoking upregulates the ACE2 receptor, and this is the same receptor on your cells that COVID uses to enter the cells. We now know there's a phenomenon called long-term COVID sufferers, or long-term COVID, long-haul COVID syndrome, which causes you to have delayed immunogenic pulmonary fibrosis. So you get scarring, reduced lung function over a period of time. Some of these patients need to take long-term steroids, and as you know from the Indian data, some of them develop quite severe fungal infections like mucormycosis, which has a very high mortality rate of 50%. Now, do these long-term COVID survivors have an elevated risk of lung cancer? That's certainly something the community has to look at in the next 10, 20 years. So you get a massive, you suddenly get a huge surge in number of people in the community with lung inflammatory changes. Is this going to impact upon lung cancer incidence in 10 years time, 20 years time? I think time will tell. Okay, so we've gone through various phases over the last 2 years in terms of our COVID community response. When it first happened in March 2020, we had extreme fear, so everybody was afraid to go out. We had very good compliance to SOPs. Stock market crash. Everybody was stood up and took notice of COVID. And then when the second wave came, SOPs were relaxed, but the COVID incidence wasn't very high, so people started to be a bit blasé. Now we're probably moving back into taking things more seriously, at least in the medical community. I mean, any of us who've treated COVID patients, and my hats off to all the frontliners in facing COVID every day. Truly, you are the heroes. But I think that there's a dichotomy in terms of our response. The public is still a bit lax. Wouldn't you say, Dr. Murali? I think they've not really grasped the severity of what this so-called third or fourth wave is.
Yep. I totally agree, doctor. And I think we've been parroting this almost every day.
Yeah. Every WhatsApp group I hear complaints of, why can't my business go back to normal? Yeah, true. I mean, I completely understand that, but I think this wave that we are seeing is much more serious than what we've ever seen in Malaysia. But anyway, get the vaccine. I borrowed this slide from one of my colleagues, Dr. Anand, and he's a huge vaccine advocate.
Yep.
So in conclusion, I think one of the other things I would really like to maybe say is that lung cancer should be managed as a team approach. So I provide the oncology approach, but through my interaction with my colleagues in the surgical field, in the respiratory field, in the public health field, you know, I'm very fortunate to have a broader overview of lung cancer than maybe if I didn't have this kind of close interaction with my colleagues. So I think in any sphere of life, I think, or not any sphere of life, any specialty in medicine, the more you understand about what your colleagues do, the better you are as a doctor. And I think it goes for lung cancer. I think it goes for breast cancer, colorectal cancer. I think general practitioners, if they're mainly general practitioners in the audience, we really encourage you to come speak to us or call me if you have a patient, or really, you know, without good general practice support, I think patients are at a loss. I think patients, you know, really need to get that support from the primary doctor that they've built a relationship over, you know, 10, 20 years, that they really trust and that know them inside out. You know, we can read from a textbook, you know, amlodipine is the best drug for you, but you as their doctor will know that's a bad idea. So I really miss this kind of interaction. I mean, I had this interaction when I was working in the UK, not so much in Malaysia, you know, where general practitioners would call me up and say, look, you know, I really think that this patient, you know, you may be a bit careful about giving them chemotherapy. I've been to them when they had, you know, X, Y, and Z heart attack, and they didn't really do well, you know. So a bit of toing and froing in a multidisciplinary approach, I think, is key to making our patients safer, to getting better outcomes from our treatments. So that's my personal moment on the soapbox and preaching about multidisciplinary care.
Right.
Thank you so much.
Thank you so much, Doctor. Doctor, there's one more question as yet, and I think very relevant to your last slide on basically this is on can a person on immunotherapy be vaccinated?
Okay, so the KKM has produced guidelines on who can be vaccinated and who cannot. At the end of the day, cut a long story short, those on immunotherapy, targeted therapy, radiation therapy can be vaccinated at any point of time. Those people on chemotherapy need a 3-month break before they're eligible for the vaccine. So just chemotherapy. There's a caveat.
Right. Right. This one on specifically on immunotherapy, Doctor.
Yes, no problem.
Okay, got it. Okay, there's another question, Doctor, from a colleague on where can we find LDCT facilities? And I'm going
Okay,
to ask
so
them to kind of get
they
you
can go to
Lung Cancer Network page.
They can go to the Lung Cancer Network Malaysia. Let me. I'm sorry. Let me. Basically, nowadays, a lot of private hospitals in the Klang Valley offer LDCT facilities. Yeah. Do you want me? Can I name the hospitals, or I mean, is that?
Yeah, sure, Doctor. I think it's fine. I'm wondering if there's a graphic that we can refer. I remember we used to have that graphic,
Correct.
which carried
Correct.
all the hospitals in the campaign.
Yes.
Trying to look for that as well.
I'm trying to look for that.
Doctor, what we will do as well is we look at the Lung Cancer Network group, but what I'll do is I'll flag back and email everyone on today's session and resend you that flyer on where you can find LDCT facilities. That I think will be helpful.
Okay. I mean, I can only speak for, I'll speak for the hospitals I work in, Beacon Hospital and Pantai Hospital. Yeah, we do. But of course, you know, that doesn't mean that other hospitals don't. Okay. Oh, I have it here. Hold on.
Right.
Okay, so here we go. This was part of our campaign that we had. We will have this campaign every November in in conjunction with Lung Cancer Awareness Month. So these private hospitals here, I won't mention their names, but you can see where they are. Have kindly partnered with us during the campaign to offer free low dose CT scans. So they have the capability and ability to offer it. But what I would say is that, you should, I mean, if the scan is totally clear, then it's fine. But if it shows an indeterminate nodule or something that needs to be discussed and considered, then by all means, contact your local respiratory physician to discuss. Some findings need to be repeated at 3 to 6 months to see whether there's any progression of the growth of the lesion. Some meet the criteria for immediate biopsy, and some are benign. They will have benign features, which probably you just need to maybe keep a track on in a year's time or 2 years' time and so forth.
Right. Got it, Doctor. Doctor, one more question from our colleague. Is tamoxifen considered as a chemotherapeutic agent?
Okay, so tamoxifen is endocrine therapy. It blocks the estrogen from attaching to the estrogen receptor for breast cancer patients, but we sometimes use it for endometrial cancer, but it's by and large is for breast cancer. It's endocrine or hormonal therapy.
Because I think what is this? That this is in connection with vaccination, and I think
Okay.
the person is now typing straight away. Can they get COVID vaccine?
Okay, understand.
Yeah.
Oops, I think I. Any more questions?
Oh yeah, no, doctor. There's this that one on hormonal therapies, and and I think it applies both to prostate or breast, and whether there's anything on COVID vaccination.
Yeah, they can, no problem.
Okay, got it. Okay, I think, Doctor, we have, I think, covered more or less quite a significant amount of issues during this time. And we've taken all the questions that we have from our colleagues, and I'm just seeing if there's any uncovered questions. I don't see any. And if not, I'm going to kind of suggest we draw this session to an end. And first of all, please, as usual, Doctor, on everyone's behalf this morning, please allow me to thank you for spending your Saturday morning with us and sharing all these wonderful pieces of information, which I hope was of benefit to everyone. And we'd also like to thank Lung Cancer Network Malaysia today, Beacon Hospital, and of course, our primary partners for this entire series, Roche Group, which is the pharmaceutical diagnostics and shared services arms of the organization, for their support on this entire series. Now, to everyone else, as I was telling you in the beginning, we're going to sign out. My colleague is just going to put up the QR code, and please feel free to scan the QR code, and that'll immediately give you attendance on your app. So thank you very much and have a nice weekend. Tomorrow, just as a public service announcement, they're reopening the Astro